To be your host today, where we'll be discussing an incredibly important topic that has given hope to millions of couples worldwide: IVF and assisted reproduction, your path to parenthood. To guide us through this topic, we have with us a distinguished expert in this field, Dr. Kritika, infertility specialist at Apollo Hospitals, Chennai. With extensive experience in reproductive health, she has helped countless couples navigate fertility challenges and achieve successful pregnancies. Dr. Kritika, thank you for joining us today.
Good afternoon. Thank you for the brief and good introduction. Can we start the session?
Yes, ma'am. Our goal today is to provide clarity on IVF and assisted reproduction and debunk myths and address common concerns so that couples make an informed decision. Whether you're currently exploring fertility treatments, have faced challenges in conceiving, or simply want to educate yourself, this session is for you. Ma'am, the first question for you: what is IVF and how does it work?
Okay, IVF is the abbreviation of the medical term in vitro fertilization. So we are assisting or aiding the process of fertilization outside the body. So how does it work? It basically works in improving the quality of the gametes, both the male and the sperm and the egg, and also helps in the act of fertilization and the transmission of the embryo through the fallopian tube in the placenta. So into the uterus. So whatever is happening inside the fallopian tube and the uterus, basically the process of the fertilization is taken care of outside the body. So it works in people in which we can make them have the successful ovulation. It helps in people who have poor quality gametes, like people who have decreased ovarian reserve, men who have poor sperm quality, both in terms of the count and the quality, and people who have tubal dysfunctions or tubal block, they all benefit with IVF. So it is having the process of fertilization assisted outside the body.
What are the different types of assisted reproductive techniques besides IVF?
See, IVF is a layman term, and most of them understand the word IVF, but I would say that 99% of the times, what we do during the process of IVF is to undergo a process called as ICSI, that is ICSI, which is the abbreviation of intracytoplasmic sperm injection. So in IVF, what we do is we place the sperm in proximity with the egg outside the body in the incubator. So say roughly 50,000 to 1 lakh sperms are kept outside the egg. But in ICSI, good quality sperm with good morphology is selected, and 1:1 ratio of 1 egg and 1 sperm. So 1 sperm is injected directly into the cytoplasm of the egg. So most of the time it is the process of ICSI which is done when we say IVF, because we tell it as IVF because most of the time people understand that term medically, and the major process which we do is ICSI. And the other things are to increase the pregnancy rate in IVF, namely, say, day 5 growth of the embryos, do the process of assisted hatching, which will help the embryo to assist and get implanted. And in a few category of patients, knowing the genetic makeup of the embryo will help them to increase the pregnancy rate and achieve a pregnancy. So we call it as a pre-implantation genetic diagnosis or assessment of the embryo. So these are the various type of IVFs or process of IVF which are done according to what medically is indicated.
What are the success rates for ICSI, ma'am?
See, basically, during the process of ICSI, we have a pregnancy rate. We take the live birth rate, that is carry home birth rate, as the real success of any infertility treatment. So the live birth rate, whenever we do a process of IVF or ICSI, supernumerary embryos are created. It's not that we are going to create only, say, 2 or 3 embryos. Depending on the capacity of the couple, more number of embryos can also be generated during the process of IVF. And so during an individual embryo transfer, we get to have the advantage of selecting the number of embryos we transfer depending upon the clinical condition of the couple. and the quality of the embryo. So the success rate is defined in terms of pregnancy rate per embryo transfer or the pregnancy rate per stimulated cycle. So in one stimulated cycle, we might have embryos that are sufficient for more than one embryo transfer. So with a single embryo, of say two good quality day 5-2 embryos, the success rate is around say 35 to 40%. And the cumulative success rate of any IVF cycle, if you have extra embryos, would be to the tune of 60-65%. This is with the self gametes, like the male and the female partner contributing to their the gamete pool. Suppose if it is a third-party reproduction, wherein the gametes quality has been poor initially, and it is replaced by a third party, say a donor gamete, the success rate would be to the tune of 90%. So with self-gamete, I would say that 2/3 of the individuals conceive. And one note of caution is do not compare it with 100%. We are not doing the procedure for patients who would easily conceive. These are people who are not able to conceive naturally, for whom the success rate or having a chance of pregnancy would be to the tune of, say, 0.5 to 1%. So for a person who has 1% chance, if I'm telling you that it will increase the chance to 65%, it is a huge number.
And when we say that ideal candidate as such is someone who is not able to conceive naturally, what are the clinical conditions which enable us to tell them that this is why they need an IVF treatment?
See, basically, whenever there is the evaluation of any infertile couple, more than an ideal candidate, I would say they are the good prognostic candidate to have an IVF. So IVF is basically offered to a person for whom the natural chances are almost nil. So whenever we evaluate a case of infertility, the first battery of investigations would be to see if there are causes of absolute like infertility. Infertility is absence of getting pregnant, and subfertility is they would still have a chance of getting pregnant, but the chance would be less. So the first battery of investigations would be to see if they are forming an egg, whether the egg is ovulated properly, and the quality of the sperm, the motility and count of the sperm. And the third factor which is evaluated is the patency of the tube. So if these three are assessed initially, IVF is still not the first line of treatment which is offered to the couple. So if they are having difficulty in forming the egg, ovulation, treatment like ovulation induction is offered. And if there are surgically correctable causes, like if they have some tubal dysfunction, tubal block, or an endometrioma. Endometrioma is a condition in which the ovary has got cyst which is filled with blood, basically. So apart from the cyst there would be pathology or adhesions in the pelvis which will prevent them to get pregnant naturally. So things which can improve the fertility, surgically correctable conditions are, the couple is advised for a surgery then. And those who do not succeed with ovulation induction or an surgery, an IUI. IUI is to inseminate or intrauterine placement of the good quality sperm, which can help people who have low quality sperm, or in people who have got unexplained infertility. So only if all these fail, IVF is given as the last resort, and around 5% of people will require an IVF. So even in these, the good prognosis, like if you're asking me the ideal candidate, an ideal candidate is the one who has got high success rate, basically. So a person who has a medically indicated IVF, and then their success rate is directly proportional to the age of the female partner. So the younger the female partner, the better is the quality of the oocyte that they are going to produce. So a person who's have a couple with an younger female partner will definitely have a better prognosis of having a pregnancy.
And when we say younger female partner, could you elaborate on the age range, please?
See, we are the young is not in terms of the younger population in Indian age group population would be around say 34, 35. We are keeping the threshold because this is the age where we find that the ovarian reserve starts reducing. The ovarian reserve is the finite pool of oocytes which are there in the ovary. So they keep reducing as the female ages. And with our genetic and nutritional background, we see that the ovarian reserve starts reducing as they advance, say, 33, 34, and we keep a mark of, say, 35 as advanced maternal age. But in the Western population, they keep around 37, 38. So an younger population is someone who's, a woman is someone who's lesser than, say, 33, 34. But the reserve will always vary. Apart from the general, this norm, the individual reserve will vary from person to person. Some are fortunate to have good reserve even at the age of 39, 40. Some of them lose their reserve even when they are much younger. So we need to assess a couple as an individual entity before we really make blanket statement.
What are the different tests which are done, doctor, for finding out how much ovarian reserve is there in a female?
See, basically, ovarian reserve, the first and the foremost is the age of the female. So the maternal age was the first factor. Apart from that, there are blood tests which will help us to find out the ovarian reserve. Before that, clinically also, as the woman has decreasing ovarian reserve, it is not manifested clinically. People tend to recognize only the hormonal cessation of the ovary. So the ovary has got two functions of one is to produce the egg, the good quality egg, which will lead on to a good pregnancy. And the other one is the hormonal component of the ovary. So people tend to recognize only when the hormone function ceases. So that is recognized as a menopause. But this ovarian function to produce good quality eggs reduces almost 10 to 12 years before the onset of menopause. And if we go into the history of the female members of the family, the menopause also has got some genetic age. So most of the time, there are families in which the women attain menopause very early in their life, and might be in the previous generation when early marriages were done. People were not really putting their effort after menopause. But now with delaying the marriage and pregnancy, we tend to see that what would have been not noticed in the previous generation gets to be noticed now. So there are people who have the cessation of ovarian function as early as, say, 30 years. The third one is the blood test. We have a battery of blood tests to see the ovarian reserve. The commonly applied one is the anti-Mullerian hormone. The abbreviation is AMH. So that is done. The other hormonal parameters are FSH and the estradiol level. And of course, we have got the ultrasound, which can give an exact picture of the ovarian reserve.
How common is infertility, doctor? And what are the primary causes in women?
See, basically, infertile couple, they contribute to 10% of the gynae OPD. So that is not very uncommon. And the main causes of infertility contributing from the female partner is the first and foremost, or the most common, what we see is dysovulation or dysfunctional ovulation, most commonly seen in the polycystic ovary syndrome patients. And the other factors might be hormonal, hypothyroid, elevated levels of prolactin, poorly controlled diabetes. And the third one would be the tubal factor, in which there is either a block in the tube or there might be dysfunction or not good function of the way the tubes have to operate. The fourth would be poor ovarian reserve, which we see, in fact, the incidence of poor ovarian reserve is increasing in the infertility clinic nowadays. This poor ovarian reserve is seen, one is the age, the other one is in women who have undergone treatment on the ovary, surgeries on the ovary. Say an endometrioma surgery or any surgeries in the pelvis can also have early onset poor ovarian reserve. These are the main causes of infertility.
How does lifestyle impact infertility, doctor? And what changes can improve the chances of conception?
See, basically, I always tell my patients that The sperm and the egg is like any other cell of the body, but it has got an additional thing to transmit our genetic material to the next generation. So anything which is optimal for health, like a high plant-based diet, which has got good contribution of plant proteins and high fiber content in the diet, all these contribute to good health and good quality gametes. And keeping the BMI in the optimal range is definitely one step towards increasing our fertility. And living in the present environment, we cannot really shut ourselves from all the environmental pollutants. But at least we need not invite new trouble by smoking or alcohol consumption or high caffeine intake. So those are some things which can improve the fertility. And definitely reducing the stress is one step forward. Definitely.
Are conditions like PCOS and endometriosis an absolute indicator for IVF?
See, the absolute indicators, PCO, when we treat women with PCO, almost 95% of them conceive with factors without a treatment requiring an IVF. Most of the time, they conceive with ovulation induction, or they might conceive with an IUI. Only 5 to 6% of women with PCO require an IVF. And even in PCO, these are it's a subgroup of PCO who have got metabolic implication in the form of high blood sugars or blood pressure. These patients have some like effect on the quality of the oocyte itself. So it's not only the process of ovulation which is not occurring in them. The quality of the oocyte itself might be compromised because of the hormonal milieu in which the ovary is there for a long time. So PCO is not an absolute indication. Even in endometriosis, most of them conceive with treatment lesser than IVF. Most of them conceive following a surgery by removal of the adhesions or correcting of the adhesions. And the main contribution or the associated factor with an endometriosis is once they undergo a surgery, it's a surgery done on the ovaries. So there is a compromise of the ovarian reserve following a surgery. So the surgeon needs to be really very careful to draw a balance between not removing too much and not leaving behind much to have a recurrence. So in people with endometriosis, the decreasing ovarian reserve contributes to the process of infertility. So if you're asking me whether PCO or endometrioma, they're not absolute indications, but endometriomas or people with endometriosis tend to require IVF much more commonly than a PCO.
Doctor, if a person has already decided they want to go for IVF, what is the stages or steps that they have to undergo till they are able to achieve conception?
See, basically, one is the preparatory phase from the patient. They optimize their health because it's not only the IVF, it is the subsequent pregnancies that they have to go through. So any medical disorders need to be kept under optimum control, say diabetes or hypertension. People need to address the health aspect before they really think about IVF treatment, because I'm telling you that we are successful in making women pregnant, but for them to have the pregnancy go on without problem and have the baby, which is not really preterm and a term healthy baby, their health need to be optimized. So the first and foremost is the health aspect. Are you asking about the process of IVF? I didn't.
Yes, ma'am.
See, basically, in an IVF, we have control over the number of embryos we can replace. So in order to increase the success rate of an IVF, our aim is to produce optimum number of eggs from the women. Because by increasing the quality, the number of embryos, we can have a better success rate. So basically, the woman undergoes a process called controlled ovarian hyperstimulation. That is making the ovaries produce a hyperstimulated more number of eggs than she would do naturally. Physiologically, we are tuned to produce only 1 or 2 eggs per cycle, but our capacity would be much more, which we term it as the reserve. So we would be capable of producing, say, 13 to 14 eggs per cycle. But physiologically, our hormonal environment is such that only 1 or 2 eggs will mature per cycle. All others will die off in that particular month. In IVF, we try to tap the entire reserve of that cycle. So injections, gonadotropins, which are similar to what our body produces, is administered to the women in the form of injections, ideally to be started from the second day of the cycle. Say you get your periods today, from the second day of the cycle, roughly for say 11 to 12 days of injections are required. And once the follicle matures, they are monitored with both blood test and ultrasound to know the optimum time when we have to retrieve the mature oocytes from the body. So the first process is the controlled ovarian hyperstimulation, followed by the oocyte retrieval. Oocyte retrieval is done transvaginally under ultrasound guidance, and it is done under anesthesia to keep the person, the woman, pain-free. It produces discomfort post-surgery. It doesn't require an incision on the abdomen. So it is a vaginally done procedure. The oocytes are retrieved from the follicle. The oocytes are identified in the follicular fluid. And depending on the process, whether they undergo an IVF or ICSI, the clinical course of the woman undergoes is the same. So once the oocytes are retrieved, depending on the quality of the sperm and the egg, a decision to do either an IVF or ICSI is taken. And the embryos are grown in vitro for, say, 3 to 5 days. 5 days is the maximum duration in which we are able to make it incubate outside the body. So at 5th day of the embryo growth, either they are transferred in that cycle itself into the uterus, or more commonly, they are cryopreserved. So we preserve it in liquid nitrogen so that the embryos can be used in the subsequent cycle. So the woman is given some injections or tablets so that the ovaries reduce in size. The embryos are frozen around the day 5, and they are frozen in such a number. See, they are stored in unit called as the cryo lock or the cryo straw. So each straw would have, if it is a good quality embryo, only 2 day 5 embryos are frozen. So subsequent cycle, only 1 straw or the cryo lock can be taken. The rest of them can be cryopreserved for any duration of time. So that embryos can be replaced into the uterus in the subsequent cycle, and we can achieve a pregnancy.
Are there any risks or side effects to IVF?
See, presently IVF is, if you're asking me, it's a very safe procedure. Okay, because people have gone through the history of very severe hyperstimulation, but with the present medication which are available, the first complication, which is an ovarian hyperstimulation, it can almost be avoided. So the aim of any IVF clinic is to have this ovarian hyperstimulation syndrome. We abbreviate it as OHSS. So OHSS, free IVF clinic, is the aim of any IVF clinic. So we have to understand this infertile couple are perfectly healthy men and women who approach medical health. So they should go back in the same health and without compromise on their health. So the first one would be the hyperstimulation, which can totally be avoided with the present day medical medicines and the support. The second one is having multiple pregnancies. So even those can be avoided. A twin is something which most of the couple would want at the end of an infertility treatment. But we are cautious not to have a twin pregnancy in women who have medical disorders. So our the counseling pre-embryo transfer, it also includes the number of embryos we would transfer subsequently. So multiple higher order pregnancies are another complication, but even that can be avoided by keeping the number of embryos which we replace, not more than 2.
What happens if an IVF cycle is unsuccessful, doctor? What are the next steps?
See, one is with the fresh transfer or with the single transfer, if there are extra embryos, they can be replaced in the subsequent cycle. But before we take a decision of what to do next if there are no more embryos, we have to, as clinicians, we go through what is the outcome of the first stimulation. Whether the first stimulation has given us embryos that are capable of giving pregnancy. Sometimes it does happen. See, it's not that we are able to generate good embryos in all couple. It ultimately will depend upon how the gametes are, whether the sperms and eggs are the only good and good sperm and egg will give us a good embryo. So we cannot have assumption that by doing an IVF we can make a good embryo out of bad gametes. So we have to see what has been the outcome of the first stimulated cycle, whether they have given us good embryos that are capable of giving a pregnancy. If that is so, then the other factor of evaluating the uterus as the environment in which the embryo has to grow subsequently needs to be done. So if the first cycle fails, we assess whether a second subsequent stimulation has to go depending on the outcome of the first cycle. So if there's something that needs to be corrected or rectified or investigated in the uterine, in the uterus or in the quality of the embryo, the chromosomal assessment of the embryo, those are done before we take a decision of what needs to be done subsequently.
Ma'am, there are so many different things that women have to do before an IVF is started. What do men have to undergo? Are there any treatments and lifestyle changes that they have to incorporate?
There is no second thought about the lifestyle that needs to be done. So, but IVF, this infertility or IVF is a clinical scenario in which the incentive is a healthy baby. So most of the men are ready to take the extra step to make the lifestyle changes. And if they are diabetic, to keep the blood sugars under control. Because what we can assess by semen analysis or the assessment of the sperm, they don't give us the entire picture of the sperm, what the sperm should be capable of doing. By looking at the sperm, we get to know the count and the motility, but we don't have any idea of whether they can produce a good embryo. So a major part of information about the quality of the sperm is not available to us. So lifestyle changes definitely has to be taken. If the BMI is on the higher side, reducing the BMI, keeping the weight under control, increasing their physical activity, having a balanced diet, having a diet which has got high antioxidant levels, cessation of smoking or alcohol, all this it can do what we cannot do once the sperm is injected into the egg.
I have some questions for you from our live viewers as well, ma'am.
Okay.
So the question number one is, I have irregular periods. Does that mean I will have trouble conceiving?
See, the regularity of cycle itself is because of ovulation. Okay. So the answer is as simple that without an ovulation and the egg, there cannot be a pregnancy. One thing is how irregular they are. If they come every 35, 40 days, might be she would still be ovulating, but not doing exactly around that 14th day, which we expect in a 28-day cycle. So if it is a 35-day cycle, she might be ovulating, say, around 21 days. So she needs to extend the duration of her having intercourse. There are methods to find out whether she's ovulating. Urinary kits are available to know when exactly the ovulation is occurring. So if it is not a really irregular cycle, say 35, 40-day cycle, and they can make an effort to know whether they're ovulating or not, either by a urinary kit or approach a doctor to see really when they're ovulating. But someone who's getting cycle only with medication, say 3 months, 6 months, 4 months, they are definitely not going to be ovulating at all. So in those, definitely the difficulty of getting pregnant would be there. The difficulty should be there.
Ma'am, the next question for you is, how can I ensure a higher success rate in my first IVF attempt?
See, the success rate is ultimately from the patient side. I cannot stress again that lifestyle changes will definitely help. It might be if they go through the Google, there is something called Mediterranean diet, which is a plant-based diet mainly. They advise even the plant source to be the protein from plant source to be the optimal protein source. And taking in lots of and avoid red meat, which will increase the chance of endometrioma and adhesions. So these needs to be done. And optimizing the BMI is one important step to increase the pregnancy rate, because the medication requirement, the medication, the effect of medications or injections, they reduce drastically as the woman BMI is increased. And how exactly, what was the question? I was...
How do they ensure that they have a higher success rate in their first IVF attempt?
So after these that they do, select a proper unit which will give them like in which there is optimum utilization of resources, a proper embryology lab. They have to put some effort to at least see a suitable a clinic, infertility clinic, which abides with the laws, which has got, they have to do some homework to see whether the pregnancy rates are good. Because IVF is done in batches in few places. Only say for 2 or 3 days, they club the cases and do. So it should be an ongoing IVF program in the hospital, which has preventive maintenance. So when they run the program throughout the year, much more care is taken to keep the culture conditions optimal. So selecting a proper infertility clinic will take a long way through for the first success rate.
And the last question for you, ma'am. I've heard that IVF babies are not as healthy as naturally conceived babies. Does this statement hold any merit?
See, one is initially, like when people have studied about the outcome, neonatal and the long-term outcome of IVF babies, there is one contributing factor of multiple pregnancies, which will lead on to preterm babies, basically. So preterm babies, if those are separately, those bias are separated. Because a preterm baby, by the nature of preterm itself, is going to have high complications. Because they stay in the NICU, the exposure for infection, all those things place them at a higher risk of having health conditions. So if singleton, that is why I told that we have to be cautious when we replace the embryos. And caution is exercised more when we have women with other medical condition. Because putting them through the multiple gestations, it's going to increase their medical complication and also lead on to preterm babies. So if preterm multiple pregnancies are separated from the outcome of, like if you consider a singleton IVF baby and a singleton normal baby, it is not found that they have increased health aspects subsequent in their life.
Thank you so much, Dr. Kirthika, for such a valuable IVF session. This session has provided much needed clarity on the subject that is often surrounded by uncertainty and emotional stress. Thank you for joining us today.
Thank you for giving me this opportunity.
Happy Women's Day to everyone, and happy Women's Day to you as well, Doctor.